Hello friends, today I am here to take up a discussion of Obs Gynae FMGE June 2022 recall questions. This is on the demand of my students. Now, my first question is, WHO defines maternal deaths as death after delivery, death from full-term pregnancy to within 24 hours of delivery, death during pregnancy and within 1 year of delivery, death during pregnancy and within 6 weeks of delivery. Always remember a very straightforward funda that purpurium is till 6 weeks of delivery. So most of the conditions or problems occurring, for example, if there is a postpartum hemorrhage, okay, secondary postpartum hemorrhage is taken 24 hours after delivery till 3rd month of delivery, that is within 12 weeks of delivery. But here maternal deaths are taken death of the pregnant lady occurring during pregnancy up to within 42 days of delivery, that is within 6 weeks of delivery. So this is a very important question from preventive obstetrics. Now, you should know what is the definition of maternal mortality rate. It is expressed as 1 lakh live births, that means the denominator is 1 lakh live births. Then most common cause of maternal death in India is obstetric hemorrhage, which is called as postpartum hemorrhage. Now, most common indirect cause of maternal mortality in India is anemia. There is already a pre-existing anemia in our country, and incidence of anemia in pregnancy in India is around 60 to 70%. Other causes of maternal mortality can be eclampsia, can be abortions, can be placenta previa, can be abruptio placentae, can be sepsis, can be infections, etc. Now, maternal deaths, it means annual number of female death from any cause related to or aggravated by pregnancy or its management, excluding the accidental or incidental causes during the pregnancy or the childbirth or within 42 days of termination of pregnancy, irrespective of the duration, irrespective of the site of pregnancy. So I hope it is clear. So it is taken within 6 weeks of delivery. Okay. Next question. There's a history of secondary amenorrhea after a DNC and hysterosalpingography image is been given in the question. Now, what is the likely cause? Likely cause, can it be a unicornuate uterus? Can it be a septate uterus? Can it lead to an Asherman syndrome, or is it a normal HSG? Now, whatever I could get from the students, I have written in the options. Maybe 1 or 2 option might be different from what is the mention in this question, because these questions are purely prepared from the memory of the students, those who have given the exam. Now, always in my sessions, I have told you, whenever you get a question from disorders of menstruation topic, and if in the question there is a secondary amenorrhea after a DNC done for a missed abortion, most likely it is Asherman syndrome. Okay. So a similar question has already been asked in the previous FMG exam and previous NEET PG questions. Okay. So typically they give the question like, there is a female in the reproductive age group. She has come with secondary amenorrhea and there is a history of DNC done for missed abortion, for inevitable abortion, etc. Okay. After that, she has developed secondary amenorrhea. And in most of the question, there is a value of FSH given 7 milli international units per ml, which is absolutely normal. So normal FSH is 5 to 20 milli international units per ml. Okay. Now, whenever you have a patient of secondary amenorrhea, the first one to do is urine pregnancy test. So, in these cases, the urine pregnancy test will come out to be negative because it is not because of pregnancy. Then, do not forget to get TSH and serum prolactin levels done because they are the systemic causes for secondary amenorrhea. The thyroid disorders and hyperprolactinemia. So there might be a question where they can mention the value of FSH, of serum prolactin, of TSH. Okay. Now, after this, if HSG has been done and it has shown that there is irregular filling defects, okay, then we should think of Asherman syndrome. Now, what will be the confirmatory investigation in this case? Confirmatory investigation in this case will be hysteroscopy. Why it is confirmatory? It is a gold standard investigation for Asherman syndrome. Number one, it will confirm your diagnosis. Number two, you can therapeutically treat your patient, that is hysteroscopic guided adhesiolysis. You can break the adhesions. Okay. So, hysteroscopy remains the gold standard investigation. Now, next question, identify the image, and this is used for. Now, this way, now I doubt they might have given only this image. So, I have added up this image just to explain that this is a Leash-Wilkinson cannula. And you know, Leash-Wilkinson cannula is used for hysterosalpingography. Now, in hysterosalpingography, what is done is this Leash-Wilkinson cannula is put in the cervix and through a syringe, a radio-opaque dye is injected, which can be a water-soluble or it can be an oil-based dye. The oil-based, when you are using, the clarity of the film is very good, but the disadvantage is pain abdomen to the patient is so much because it will take longer time for the dye to get absorbed from the body. Whereas when you are using a water-based dye, the pain abdomen to the patient is comparatively less and it is absorbed from the body at a faster rate. Okay. So, radio-opaque dye is been put and this is the Leash-Wilkinson cannula and it is used for doing an HSG, hysterosalpingography. Now, you might get an image of the hysterosalpingography which they have asked in the NEET PG exam 2018, that a normal HSG image. Okay. So, when you are putting a dye into the uterus, you click X-ray film number 1, dye entering into the fallopian tube, film number 2, and then free spill of dye, that is film number 3. So, HSG is a normal investigation to be done in cases of infertility, and you will have idea about uterine pathology. You can get idea about uterine pathology, like there may be a space occupying lesion. That space occupying lesion can be submucosal polyp or it can be submucosal fibroid, or you can pick up Asherman syndrome like in the previous question I have discussed, or you can pick up congenital malformations of uterus like a septate uterus or like a bicornuate uterus. But HSG is one of the main investigation for tubal patency. Okay. So, number one, you can have idea about uterine pathology like submucosal polyp, submucosal fibroid, Asherman syndrome or congenital malformations of uterus, and it is again a very important or basic investigation in infertility case for a tubal patency. Now, this is a normal HSG image where you can see this is a Leash-Wilkinson cannula. Dye is been put and you can see the normal uterine outlining. You can trace the fallopian tube and you can see the free spill of dye. So this is a normal HSG. Sometimes you can get an image like this. This is a bilateral proximal tubal block. You can get an image like this. That is a bilateral hydrosalpinx, which is a presentation of PID. You can get an image of a beaded appearance of fallopian tube, beaded appearance, or you can get an image like lead pipe appearance, which is a genital tuberculosis. Okay. So that is a presentation of PID and infertility. Now, next question. 2 doctors' opinion is needed for doing an MTP. Now, if the period of gestation is. Now, this is a question and I am going to tell you from both ways. If in this question, it is written as New MTP Act 2021, then I am going to mark my answer as period of gestation between 20 to 24 weeks. Now, I don't think the question will be asked on the basis of 1971 MTP Act because answer has been changed and everywhere we follow the latest MTP Act 2021. Now, what is the basic difference in the two? Let me explain. The MTP Act 1971 and the MTP Act 2021. Now, the basic difference was here the MTP was legal up to less than 20 weeks. Here the MTP is legal when it is done up to 24 weeks. So, the upper limit has been increased to 24 weeks. Number 2. Opinion of one doctor needed. If MTP is done in less than 12 weeks, opinion of 2 doctors needed. If MTP is done between 13 to 20 weeks. Here, opinion of 1 doctor needed if MTP is done up to 20 weeks and opinion of 2 doctors needed when MTP is done between 20 to 24 weeks. Now, one latest point in MTP Act 2021 is if there is a rape victim or a special cases and if the pregnancy has gone beyond 24 weeks, then what is to be done? In that case, the case will go to the medical board which consists of a gynecologist, pediatrician, radiologist and an official gazetted officer appointed by the state government. And this board will decide that MTP has to be done or not. Most of the time, this board is in favor of the victim or favor of the patient and they give the permission for performing the MTP on the social grounds in such cases. Now, in 2021 MTP Act, The difference is that the upper limit has been increased to 24 weeks because there was a very much important need for modification of the previous MTP Act. Okay, and one registered medical practitioner can terminate the pregnancy up to 20 weeks. 2 RMP needed or opinion of 2 doctors needed when MTP termination has to be done between 20 to 24 weeks. Okay. Now next, most common site for genital tuberculosis. This is a very basic question. It is fallopian tube. Now 90% of the genital TB lies in the fallopian tube, and the most common presentation of genital tuberculosis is most of the time infertility. Okay. Then next, second most common site for genital tuberculosis, around 50% cases are in the uterus, and then next or the third most common site is the ovary. Nearly around 30% cases lies in the ovary. Now, in cases of the genital tuberculosis occurring in the uterus, it is called as tubercular endometritis, and it can present with the menstrual disturbance like menorrhagia. Later on, it can lead to secondary amenorrhea, oligomenorrhea, and finally to the secondary amenorrhea. Okay. In this case, the investigation done is premenstrual endometrial biopsy, and you send it for in the normal saline for acid-fast bacilli, in the formalin for histopath where you check the tubercular granulomas. And if confirmatory the tuberculosis is been picked up on the investigation, then the treatment remains the ATT, anti-tubercular treatment. Next, a 60-year-old presented with postmenopausal bleeding, and what is the likely cause? Postmenopausal bleeding, most common cause for postmenopausal bleeding, 70% cases postmenopausal bleeding is caused by senile endometritis, which is also called as atrophic endometritis. Senile endometritis, which is also called as atrophic endometritis. Only 10% cases of postmenopausal bleeding is caused by cancer endometrium, and this is worldwide. Okay. In India, the incidence of cancer cervix is high. So in India, cancer to cause postmenopausal bleeding remains cancer cervix. Okay. And usually the presentation is irregular vaginal bleeding. Okay. So here the answer is endometrial atrophy, which is called as senile endometritis or atrophic endometritis. One more thing I would like to mention it here. Whenever there is a case of postmenopausal bleeding, always our first investigation is get a transvaginal scan done to check for the endometrial thickness. And cutoff value for endometrial thickness in a menopausal lady is 4 mm. So, if the value is coming out to be less than 4 mm, you need to put your patient on follow-up. And if the bleeding occurs, then you go for the investigation of choice, that is endometrial sampling. Okay. So, in TVS, it is less than 4 mm. So, you are going to keep the patient on follow-up. Suppose bleeding occurs, then you go for investigation of choice, that is endometrial sampling. And if the endometrial thickness comes out to be more than 4 mm, then you go for office endometrial biopsy, or also called as endometrial sampling using a pipette or using a Carman's cannula. Okay. And if suppose the endometrial biopsy report shows negative, but bleeding is persisting, then you go for investigation of choice, which is DNC plus hysteroscopy. So nowadays, just remember what is the investigation of choice for a case of postmenopausal bleeding where endometrial thickness is coming out to be more and endometrial sampling report comes normal, then you go for investigation of choice, or you can say rather the gold standard investigation, which remains DNC plus hysteroscopy. Advantage of doing hysteroscopy is we can look for any suspicious areas, okay, and we can take the biopsy from the suspicious areas. So that is what is an advantage. And don't forget that a cause of postmenopausal bleeding can be an endometrial polyp. So doing a hysteroscopy will have extra advantage that you can resect out this polyp and send it for histopath, and most of the cases it comes out to be benign, but some cases it can be malignant. So endometrial polyp can be malignant, and then a suspicious areas of uterine cavity, the biopsy can be taken up. So further to rule out a case of endometrial hyperplasia can be a finding, or endometrial cancer can be a finding. So always remember, in postmenopausal bleeding, your first investigation is a transvaginal scan to check for endometrial thickness. Now, I have already explained this particular point that you check for the endometrial thickness, and if it is less than 4 mm, this is normal. If it is more than 4 mm, I have explained. If the endometrial thickness is more than 4 mm and there is some focal thickness, in that case, your further investigation remains hysteroscopy. Okay, because it will have an extra advantage. Or suppose there is some fluid in the uterine cavity, then again I would like to go for a hysteroscopy because it might be a case of pyometra. Pyometra can be because of a senile endometritis, pyometra can be because of cancer endometrium, or it is a side effect of, it can be a complication of the cancer cervix as well. Now, this is endometrial aspiration cytology, which I have just explained, and this is a pipil. Most of the Western countries, they are using this pipil and they are doing an office endometrial sampling where it is an OPD procedure. But in our country, we are using a Karman's cannula, attaching a syringe, and we are aspirating the endometrium and sending it in a formalin vial for histopath. Okay, sending in the formalin vial for a histopathological examination. Next. Now, what is the contraceptive present in this? There is an image given, and I don't think today must have been written in that image. Only this image would have been given in the exam. The students who have given the exam, they are the better ones to tell. So this is a vaginal sponge. It releases a spermicidal agent, nanoxynol 9. Nanoxynol 9, and failure rate of vaginal sponge is 9 to 30 per 100 women year. So, what spermicidal agent? It has been impregnated. It has been impregnated with nanoxynol 9. Okay. Now, one thing I want to add up here, spermicidal agents. Spermicidal agents are surface active agents. Spermicidal agents are surface active agents. Spermicidal agents are available in the form of creams, in the form of jellies. If this is the structure of sperm, it has got a head, acrosomal cap, middle piece, and a tail. Acrosomal cap contains autolytic enzymes. So these spermicidal agent cause dissolution of acrosomal cap. So in a way, the sperm get neutralized. Okay. But if used alone, the spermicidal agent has got high failure rate. Okay. Near about 20 to 25 per 100 women year. Okay. So spermicidals are always advised to be used along with the barrier contraceptive, because if there is a slippage of the barrier, for example, it is very commonly used with the female barrier, that is a diaphragm, that is a Dutch cap. So if there is any slippage of the diaphragm, then spermicidal agents which has been added with that, it will take care of the released sperm, so the failure rate of the barrier contraceptive can be minimized in such a way. Okay. Now, placenta in humans is hemochorial, epitheliochorial, endotheliochorial. So correct answer is, I have always been teaching in my classes, it is hemochorial. Hem means blood, chorial means fetal membranes. Now, what is the weight of the term size placenta? Is 500 grams. What is the blood in the placenta? 500 ml. What is the ratio of placenta to fetal weight? Is equal to placenta to fetal weight is 1:6. When is the weight of placenta equal to the fetus? Around 17 weeks. How is placenta formed? Placenta is formed from the maternal side, called as decidua basalis, and from the fetal side, called as chorion frondosum. So this is maternal side, decidua, and fetal side is chorion frondosum. 80% of the placenta at term pregnancy is formed by the fetus. So placenta is purely a product from the fetus. Okay. Now, just to add on to this particular point, now what is this image? This is a battle-door placenta. Battle-door placenta means umbilical cord is attached to the margin of placenta. Okay. Umbilical cord is attached to the margin of placenta. This image-based question has been asked. Now, this one is a filamentous insertion of placenta, whereas umbilical cord is attached to the fetal membranes. Umbilical cord is attached to the fetal membranes. So, as the labor progresses, there will be, shearing of this umbilical cord and the fetal membranes, and it will lead to a condition of APH that is called as vasa previa. Vasa previa, where the blood is a cord blood, so it is fetal in origin. So baby is born as pale. Now, there is another type of placenta that is called as succensurita lobe, which is an accessory lobe of placenta. That is an accessory lobe of placenta, and it leads to secondary postpartum hemorrhage. So, baby is born, placenta is delivered, and after 24 hours, the lady comes with excessive bleeding. So, that leads to the retained bits of placenta, which can be a succinturita lobe. So a gentle curettage is going to treat the patient. So this is a Battledore where umbilical cord is attached to the margin of placenta. Number 2 is a filamentous insertion where umbilical cord is attached to the fetal membranes, and this leads to a condition which is called as vasa previa. And number 3 is accessory lobe of placenta, which is called as succinturita lobe, that can cause a secondary postpartum hemorrhage.